I'm Jonathan Courtney, orthopedic surgeon in Boca Raton, Florida. Talking about my paper, short-term clinical outcomes with a new dual taper wedge femoral stem in total hip replacement. I don't have any financial disclosures regarding this stem, but I am a design surgeon with this company on revision hips and a total knee replacement. So quick background, total hip replacement is one of the most successful surgeries of all time. More and more total hips are being performed in ambulatory surgery centers. In the United States, there's a large emphasis being placed on the overall cost of these surgeries. I own 2 different surgery centers, and every week we have meetings how to reduce costs. I get yelled at, if I go over anything. So we're always trying to see how can we save costs, not just for our center, but for the overall system. The number one driver for cost was implant costs for hip replacements. This is actually a European study that taught us this. So, we like to debate. There's debates as to what's the best way of doing this. What's the best approach? Is it anterior approach, posterior approach, lateral approach? Do we use manual instruments to do this? Do we use a robot to help us do this? And then there's implant type. What's the best type of implant to do for this? So the use of dual tapered press fit femoral stems have been increasing in its popularity. And basically what it is, it's the picture all the way on the right. The picture all the way on the left, that's kind of an axial cut of what the proximal femur looks like when we cut it. The middle picture is the classic wedge, cementless wedge type of hip replacement. And the one on the right is the dual taper. And you can see it really gives better canal fit. It allows minimally invasive surgery access. We can make tiny little incisions and put this in. We do have good long-term data with these stems. And it's a broach-only stem. We don't have to do reaming. We don't have to do major work. It takes about 5-10 minutes to put one of these stems in, even in my hands. But they do have their worries. There's concerns about increased risks of periprosthetic fracture. Some studies do show increased rates with this. They can also have subsidence of the stem. We'll put the stem in, and the patient start walking on it, and the stems can subside a little bit. Now that's concerning because that can lead to instability, leg length discrepancy. It can also lead to thigh pain in some patients. So the signature Everglade stem is a new stem. It's a dual tapered press fit stem. It flares in both the medial lateral dimension, but also as well as the anterior posterior dimension. It leads to decreasing voids in the femoral canal, as we saw in the picture 2 slides before. And it's a true fit and fill stem. Plus, it allows the broach-only preparation. This is kind of what it looks like. I like the cool green coloration. I think that's something different. It doesn't mean anything. I asked the CEO why. He goes, because it looks cool. So I kind of like that. One of the benefits of this stem is I can have 3 different neck options, which allows me to change the offset or the width of the hip without affecting the length. A lot of times when I'm doing a hip replacement, you feel it's a little unstable. I want to add offset without affecting the length. And now I have to start doing math. How much do I put? With this, I don't have to do any math. I can just focus on the surgery. I need more offset. I go on my offset stem. I don't have to think about what that's doing to my leg length. This stem has proximal hydroxyapatite coating for good bony on-growth. And you can see distally on the bottom, it's nice and polished, and it's really nice and thin, so we don't get potted distally in the femur. A lot of times, we have like those stubby stems, we put it in and we feel like, oh, we have good stability, but we really don't. Patient starts walking on it, and now they split their femur open. And it's a new stem, was released in 2022. So some questions. Is this a safe stem to use? Yes, it's cool and green, and I got offset options, but is it safe to put this in patients? What are the short-term outcomes with this stem? And does this stem provide value? It's really important now. If we're going to go to a surgery center or a new hospital system, does it have value? Because we already have stems out there. There's a lot of stems out there. Why use this? So I performed a retrospective chart review of my first 100 hips using the Everglade stem. All patients were performed in the ambulatory surgery setting. Preoperative and postoperative outcome scores were evaluated. I used the HOOS Junior form, which is the hip osteoarthritis outcome score. It allows us to ask 6 different questions, and we get a pretty good validated scoring system from 0 to 100. 100 being a perfect hip, 0 being no hip. Postoperative x-rays were reviewed, assessing for fracture, subsidence, or any radiolucencies around the stem. If you see a radiolucency, that tells you that stem is loose. We did get IRB exemption for this study because it was a retrospective chart. I did a direct anterior approach on every patient. We used a standard operating room table. I did use fluoroscopic imaging during the surgery, during the trialing of the implants, and then after the actual implantation of the prosthesis. We got fluoroscopic images to make sure that the sizing was good. Patients were discharged home a couple hours after surgery. They were weight bearing as tolerated. And then we had 2-week, 6-week, 6-month, and then 1-year follow-up visits. And for our results, it was 100 patients, 41 men, 59 women. Their mean age was 68 years old. The mean follow-up was 317 days. The pre-op WHO score was 57. The 6-week WHO score went up to 86. At 6 months was 93, and 1 year was 94.3. There were no incidences of stem subsidence, paraprosthetic fracture, or radiolucencies. No stems were revised, but I did have 2 revisions of the femoral heads for instability, which I'll show you in a couple minutes. Discussion. In 2021, the American Joint Replacement Registry reports that 96% of all hip replacements that are done are using non-cemented fixation. A recent systematic review concluded that non-cemented femoral implants with double wedge geometries are associated with, it's actually 3 times higher risk of paraprosthetic fracture. So we reported on a new femoral prosthesis, the Signature Everglade, which is non-cemented double wedge implant. Our results showed that the short-term results, this stem is safe. We had no fractures or subsidence. There were no other femoral implant-related complications. The Everglade has been shown to be a good quality implant. The definition of quality, as defined by Gonabedian, is the deployment of a medical technology that maximizes health benefits while minimizing the health risks. Right? There were no complications associated with the femoral stem itself, and yet we had really good outcome scores, so this is a good quality stem. The pre-op Hoos Jr. scores 57 at 1 year, 94. Well, the Hoos Jr. has been shown to be valid, reliable, and a responsive measure of hip health for patients undergoing total hip. It's a short form patient-reported outcome that's patient relevant and efficient. And, you know, we have a pretty high volume practice. So for me, it's pretty easy to do this. I just have my medical assistant ask the patients questions, while they're sitting down in the chair. So it's pretty easy to do. So a lot of people tell me, I don't have time for it. It's hard to say no to this. So what is value? Value is quality over cost. The best ways to increase the value is either you have high quality or you decrease your cost. Well, the stem has been shown to be good quality. And the cost is, I shouldn't be talking cost, but it is important. It's about $600 lower than comparable stems. So this is a high value implant with high quality and we've lowered cost. This is just a case example. This is my first patient. This was a 66-year-old male. He had left-sided osteoarthritis. See there's bone on bone on the left hip there. His pre-op Hoos Jr. was 58.9. He underwent left total hip, and at 6 weeks, and then at 6 months, his Hoos Jr. was 100, and he probably didn't follow up at 1 year because why would he? His hip is perfect. Now, not all that glitters is gold. We did have 2 complications in this cohort, both with recurrent dislocations that necessitated revision of the femoral head. This first one here, 73-year-old female. She had severe left hip pain due to arthritis. She underwent a left total hip. Again, here's her post-op x-ray. At 2 weeks, she did well, but then she got out of bed, she tripped and fell, and she dislocated the hip. She was taken to the emergency room. They popped it back in. At 6 weeks, she came back to see me. She had a WHO score of 100. So I'm patting myself on the back. I'm the greatest thing. But 2 months after surgery, she was involved in a car accident and then had another hip dislocation. After that, she had subjective feelings of instability. She was complaining that anytime she twisted, anytime she bent, she felt like something was happening, but it didn't physically pop out again. But she's had 2 episodes of dislocations. Now she's having subjective instability. Took her back to the operating room. The stem was found to be well fixed, so I basically had to pop off the old head. I put a new head and lengthen her a few millimeters, both the width and the length. And now it's feeling much more stable. Unfortunately, this poor girl, now she has, from the accident, cervical myelopathy and needs to have cervical spine fusion. And her Whose score dropped down to like 50 something, really because of her myelopathy, but you know, that's included in the study. And then the next revision we did is the 79-year-old female. She had severe right hip pain, secondary to arthritis. She underwent the right total hip, really without incident. 6 weeks post-op, she was walking unassisted, no pain. Her Hoosh Jr. was 85. But 8 weeks after the surgery, she was bending over in the shower. She felt her like pop out of place and pop back in again. And then again, 9 weeks after the surgery, she was lying in her bathtub. She said she felt it pop out, but it went back in on its own. I'm not sure what she was doing in the shower or bath, but that's, for me, 2 instability events, and that kind of twisted my arm to revise. So took her back, and we also revised her head. We lengthened it and widened it, and she did well. 6 weeks out from that revision, she had a Hoosh Jr. of 85, walking unassisted without pain. So in conclusion, the Everglades stem is safe. The Everglades stem does show good short-term outcomes, both clinically and radiographically. The Everglades stem does have high value. You know, a major limitation is that this is a retrospective study. It's short-term outcomes, and you know, future prospective blinded studies with long follow-up is really needed to compare this stem with other contemporaneous stems on the market. Here are my references. Thank you.